At my institution, we routinely will check HER2 status based on immunohistochemistry as our first screen. And in those select cases that score as 2+, we reflexively do FISH testing thereafter. And the definition of HER2 positivity or amplification that we follow aligns with the ASCO-CAP modified guidelines for HER2 positivity. This particular patient had a tumor larger than 2 centimeters in size, and she happened to have node-positive disease. At my institution, either of those criteria would select for a patient that we would recommend neoadjuvant therapy in the setting of early stage HER2 positive disease. And so once we've made the decision to deliver neoadjuvant therapy, my preference is often dose-dense AC followed by weekly paclitaxel with trastuzumab and pertuzumab. Evidence from APHINITY would suggest TCHP is also a supported regimen. What I often will do is plan to continue the dual HER2 targeted therapy in the adjuvant setting to continue out a year. Although recently the KATHERINE data would suggest that there is a benefit to refining our adjuvant treatment, at least in terms of HER2 targeted therapy, based on the results of surgery and the response to neoadjuvant therapy. So when patients achieve a pathologic complete response, I continue the trastuzumab and pertuzumab doublet to finish out a year. However, in those patients who fail to achieve a pathologic complete response, the KATHERINE data would support using TDM1 for the remainder of the year. And that is based on almost a 50% improvement in invasive disease-free survival when making that change from trastuzumab-based regimen to TDM1. In the adjuvant setting following neoadjuvant therapy, the treatment choice is largely dictated by whether somebody has achieved a pathologic complete response or not. And the KATHERINE data that was presented and published recently is what has informed that treatment recommendation. So in patients that were deemed to be high risk enough to warrant neoadjuvant therapy, even in the setting where they may be node negative but had a large tumor size, our practice would be to continue trastuzumab and pertuzumab to finish out a year if that patient achieved a pathologic complete response. However, if they failed to have a pathologic complete response, the KATHERINE data would support switching to TDM1 in the adjuvant setting for an additional, about year of therapy. And that KATHERINE data supports the use of TDM1 based on both about a 50% improvement in disease-free survival or invasive disease-free survival, and almost a 40% improvement in a distant recurrence. So those are meaningful endpoints, and I think that the KATHERINE data have really been practice-changing. The use of neratinib in the extended adjuvant setting is based on data from the XTENET study. We have to remember that this is a trial that began several years ago, almost predating our current utilization of pertuzumab in the adjuvant setting. So that trial demonstrated an improvement in the use of 1 year of neratinib following 1 year of adjuvant trastuzumab therapy for patients with HER2 positive early stage breast cancer. The benefit in disease-free survival was really limited to the subset of patients that had hormonally driven disease. And so I think that we are left to extrapolate whether there would be a benefit to using neratinib in the extended adjuvant setting now when our practice is incorporating pertuzumab and even potentially TDM1. We don't have those data in terms of efficacy. We do have some safety data from other sort of post-approval trials. And I would say that I consider the use of neratinib in the extended adjuvant setting for my highest risk patients who have ER positive, HER2 positive breast cancer, node positive disease. And I entertain the discussion of using neratinib as we're approaching the end of that 1 year of adjuvant HER2 based treatment.